please don't feel like you'd have to turn around and listen. You can listen while you're eating dinner. But I'm going to talk. I'm the sort of surgical component of this practice, and I'm going to talk about a few issues around surgery. Much of which you will have heard before. Things like the evidence for surgery, the different options that are available. I'm going to speak a little bit about the patient experience, in my experience, and we're going to talk about the role of long-term follow-up, because I think that's important, and I think that the previous two speakers have touched on that. The fact of the matter is, obesity is a chronic disease, and these people need to be managed into the long term, indefinitely in fact. So I might just, before I kick off, just ask who in the room... I'm almost shouting. I do have a bit of a cold. So I might just, before I start, ask who in the room has a patient who's had a laparoscopic bariatric operation? So a few, yeah, I guess about half. So it's certainly not cutting edge anymore. Laparoscopic and certainly open weight loss surgery has been with us for many, many years. The data supporting it is very sound, and the data supporting durable weight loss into the long term is very sound too. So it's kind of, surgery is kind of for the severely and morbidly obese patient. It's the gold standard of treatment. And I've been in the bariatric surgery space for around about 15 years, and like a lot of surgeons doing advanced laparoscopic and upper GI surgery, I started doing lap bands probably around about 15 years ago now. So I was doing lap bands for first up procedures, and there'd be patients who'd previously had stomach stapling procedures or VBGs, and in those patients I would do an open gastric bypass. These days, most surgeons are doing a lot of bariatric surgery, and most patients in the country, if they're coming along for a first up weight loss operation or laparoscopic operation, they're going to be having a sleeve gastrectomy. So these procedures have been around for a long time. There are surgeons like me who've got more grey hairs than blonde hairs now, who've been doing it for a long time, and there's a really good, in Australia, we're lucky to have a good collective experience as far as weight loss surgery goes. So what is the evidence for surgery? And I really think our own personal experience should be counted in terms of value or high value experience. So those of us in the room who've got patients who've had weight loss surgery will attest to the fact that patients they rarely ever regret having a weight loss operation, particularly a sleeve gastrectomy. They get predictable marked weight loss, they have an increased quality of life, and they experience a broad improvement in comorbidities. Okay, so the improvement in comorbidities, particularly diabetes and sleep apnea, with weight loss surgery is profound, and there's plenty of evidence to that effect. There's loads and loads of randomised controlled trials and meta-analyses and case cohort studies to attest to the benefit of laparoscopic weight loss surgery. So it really is the gold standard when we're talking about patients with morbid obesity. Not only that, do they experience morbidity resolution, increased quality of life, but there's also some pretty good evidence to attest to the fact that they live longer. They have a longer life expectancy than obese patients who don't have surgery. And finally, guidelines. There's now guidelines, and I think Shamani put some guidelines up from a local group with recommendations to who should appropriately have weight loss surgery. So just to look at some of those studies, the Swedish obesity subject study is a study that everyone who's looking after obese patients probably knows about. It's a sort of a case-matched cohort study. It's been going since the 70s, and essentially what they did in Sweden is they got just under 1,500 patients who were obese, morbidly obese. They had surgery, different types of surgeries you can see over there. They matched them with, pardon me, obese patients who weren't undergoing surgery, and this is a curve that most of us will be familiar with. Those who didn't have an operation didn't lose much weight over the long term. Those who had surgery, different types of operations than we do these days, apart from a gastric bypass, lost a lot of weight, and they kept the weight off into the long term. Much longer than the 20 months or 24 months short-term papers that we've seen with lap bands and the endoscopic treatment. These patients kept their weight off into the long term. There's certainly some weight regain with all these procedures, and that's important, I think, to note. But nevertheless, weight loss compared to non-surgical controls is pretty significant. I said earlier that this study looked at survival. This is a publication from later on down the track when this cohort of patients had been examined for a bit longer. This one's from August 2007. And what do you know? The patients who had surgery had a lower mortality rate than the patients who had not undergone surgery. So these are morbidly obese patients. These ones had an operation. These ones didn't have an operation. And the survival curves look like a survival curve you'd see, from an oncological intervention. So very impressive. And in the same edition of the New England Journal, this sort of retrospective cohort study was presented, and again, survival, or at least sort of looking at survival in a different way, but certainly patients who'd undergone surgery had a lower mortality rate than patients who hadn't undergone surgery. So that's pretty profound. That's a pretty important bit of data to acknowledge. These are more recent, or this is a more recent study. This is a study that everyone on this table at least would be familiar with, and anyone who's looking after bariatric patients would be familiar with. And that's a study where they randomise obese diabetics into medical treatment, best medical treatment, as Shivani's outlined, sleeve gastrectomy or laparoscopic bypass operation. And they looked at diabetes control into the long term, or 5 years at least, much better in the bypass and sleeve groups compared to the medical group. And similarly, with weight loss, certainly, probably, I would reckon Shimani would be better placed to comment than me, that the medical group didn't do too badly, but certainly nowhere near as good as both surgical groups. And in terms of knocking off their insulin and getting down to no medication requirement, the surgical groups do much better than the non-surgical groups. There's plenty of other evidence for other resolution of comorbidities, including sleep apnea, you'll be familiar with, hypertension, cardiovascular disease. I think Shamani mentioned osteoarthritis and degenerative joint disease, infertility in young women who've got metabolic syndrome, and of course quality of life. So all of these comorbidities are markedly improved with weight loss surgery. I'm going to have a drink. I have got a bit of a cold, so I'll just grab my drink. So these are guidelines that might be familiar to you, and they recommend bariatric surgery as being useful in patients who've got a BMI of 35 or over with comorbidity, or a BMI of 40 or over. So these are local guidelines. These guidelines are from a diabetic summit, and they recommend weight loss surgery in diabetics who've got a BMI of 40 or over, or a BMI of 30 or over, with significant with poor control. So pretty profound recommendations as far as surgery goes. I'm very sorry, I've got a cold. I'll just take a sip. Let's just have a look at this slide. These are the options for surgery these days. So this is the operation that is most commonly performed in Australia, and that's called a laparoscopic sleeve gastrectomy. So it's a resectional operation where we remove most of the stomach and we leave a non-distensible gastric sleeve. Okay, and that puts brakes on pretty firmly to people who have got morbid obesity in terms of their portion size. These bypass operations have more of a profound metabolic effect, and they're used in people particularly who've got brittle diabetes, or reflux disease. So my go-to operation will be a sleeve gastrectomy. If I've got a significant or an important indication to go ahead with a metabolic operation, I'll do some sort of bypass or other. And that's how it's sort of playing out at a local level, certainly amongst surgeons in Australia and New Zealand. Most surgeons will do a sleeve gastrectomy. That's the most commonly performed operation in Australia at the moment. Lap banding used to be done in about 25% of patients as recently as a couple of years ago, but that's narrowed down now to less than 10%. So most patients who are having a weight loss operation will end up having a sleeve gastrectomy. You'll note up here that there are a number of patients who are having surgical reversal, and guess what that is? That's removing lap bands. So lap bands are going down in popularity, as there's evidenced by this, and a lot of patients are having their lap bands removed. So a lot of surgeons like me who are in a sort of a high volume environment are doing a lot of what's called revisional surgery, so converting lap band operations to bypasses or sleeves. This is a sleeve gastrectomy. As I say, it's the most frequently performed procedure. 5 keyhole incisions, so it's a laparoscopic procedure. All these operations are laparoscopic. The patient spends a couple of nights in hospital, and as I say, it results in a mechanical restriction. Okay, so there's the stomach that's being resected. This is the stomach that's staying behind, and it becomes a pretty narrow, low volume, non-distensible conduit. There's some metabolic effect as well, and patients who've had sleeve gastrectomy tend to report a decrease in appetite and early satiety. There is a price to pay in terms of complication. There's a leak rate of around about 1 to 2%. Okay, and that's a significant complication. Thankfully, it happens infrequently, but patients who have a leak require more intervention, they require antibiotics and a longer hospital stay and so on. So it's certainly not to be sneezed at. But the excess weight loss is significant. So patients who have a sleeve gastrectomy would expect to maintain that sort of weight loss up to around about 5 years and beyond. Bypasses, as I said before, in my practice, I tend to reserve for patients who've got multi-therapy diabetes or who've had previous surgery or have significant problems with reflux or hiatus hernia. Certainly, as you saw in that Stampede paper, probably a little bit better diabetic control in a patient with undergoing a bypass operation than a sleeve gastrectomy, but there is a higher risk of long-term complications than with a sleeve gastrectomy. So anatomical complications like hernias and adhesions and so on, and also metabolic complications like micronutrient deficiency and so on. So good operations, certainly not my go-to operations, bypasses, but again, very good excess weight loss into the long term, a little bit better than a sleeve gastrectomy. So I'd always do a sleeve gastrectomy as my default procedure. I'd consider bypass in patients who particularly want a bypass operation. There's plenty of them around. Usually if I'm doing revisional surgery for my lap band, I'd consider a bypass, although I often do a sleeve. In patients with these indications, pardon me, I'll go to a bypass operation rather than a sleeve gastrectomy. I think, as has been alluded to earlier by the other two speakers, it really is important to treat our morbidly obese patients in a multidisciplinary environment, and that's why I think working through Healthy Weight Australia represents best practice. Patients are all seen by an endocrinologist, Shamani. They have a number of investigations preoperatively. We know that there is a high rate of sort of occult sleep disturbance and sleep apnea in these obese patients. We know that might explain their hypertension. We get them all to, if they're going to go down a surgical pathway, certainly, or an interventional pathway, it's important that they're seen by a dietitian, an exercise physiologist and a psychologist, and it's important that the patient knows that they're in for the long haul, that this is a intervention that's going to address their disease into the long term. So surgery is done. I operated three hospitals, I should say, HSS, Norwest and the Sand Hospital. Patients come in on the day of surgery. The operation takes a couple of hours, so total operative time and anaesthetic time takes a couple of hours. They start clear fluids on the day of surgery. They stay 2 or 3 nights in hospital, and then they go home on a liquid diet, oral painkillers and some acid suppression. And then patients are seen by the dietitian. In the short term, they progress from a liquid diet after a couple of weeks to a puree diet and so on. And there's a pretty well-trodden pathway in terms of dietary escalation. So this is as close as I get to awful videos, some pretty awful stills, I guess. But this is what we do with a sleeve gastrectomy. This is the stomach when it's been mobilised. So along here, this is where the greater omentum sticks onto the stomach. So we cut along here, all these little blood vessels have been divided. It's been disconnected from the spleen. And then what we do is we get the anaesthetist to put a bougie down, which is like a soft rubber tube, and then we cut up against it. So this is the sort of first firing. This device here puts in a row of staples and then cuts along the middle. We do that a few times, running up hard up against the bougie, and that leaves us with a predictable volume of stomach. Pardon me, if you look closely, you can see the staple line there. most or many surgeons will use buttressing to prevent bleeding. So as you can see, it's a pretty dry operation. Surgeons have got to make sure they get rid of all the fundus. Okay, the fundus is that big bulgy part at the top of the stomach. If you leave that behind, food will go in there. Patients will, they'll be able to eat more, but they'll also get a lot of reflux and so on. So that's one of the important or salient points about weight loss, about sleeve gastrectomy. So follow-up. I really do want to make a point about follow-up, because I think what the Achilles heel of all of these procedures is poor compliance and poor follow-up. And the fact of the matter is that surgeons, interventionalists are not going to be able to see all of their patients for the rest of their life. And so I think this is particularly important that primary carers sort of step up and acknowledge the fact that they have to, that it's important, that it behoves you to follow these patients knowing that they've had a weight loss operation that has affected their physiology. So we do get a change in GI physiology with these operations. Nutritional follow-up needs to be lifelong. It needs to be with either and/or dietitian, GP, and a surgical clinic, depending on what the local resources are. There are some guidelines for that nutritional follow-up. So these patients, particularly if they've had, particularly if they've had a bypass operation, really do need to have their micronutrients looked at closely. And if there's any, and they all need to be on tailored micronutrient supplements. And if there's any problems with any of them, they need to be referred back to their dietitian, back to their endocrinologist, and in some cases back to their surgeon. Lifelong surgical follow-up is important as well. So surgeons who are going to practice in the weight loss surgery space need to be available to see their patients into the long term. And I would want to see my patients, a long way down the track if they were suffering from weight regain. Okay, so if a patient has a sleeve gastrectomy or indeed a lap band and they're regaining weight down the track, sometimes that can be addressed through surgical intervention, although it shouldn't be the first protocol. The first protocol, a patient with weight regain should be to see their dietitian again, see their EP again, and so on. Some patients into the long term, particularly bypass patients, might get in trouble with surgical complications, okay? And so a surgeon needs to be available to see those patients without delay. And more often than not, problems that occur in terms of weight regain with bypass patients into the long term can be addressed by the likes of an interventional endoscopist if it comes to slightly modifying the anatomy of the bypass. So I think all patients with a BMI 35 to 40 or above need to have access to an informed decision about weight loss surgery. Doesn't matter who they have it with. They certainly don't have to have it with the surgeon, but if they have an informed discussion with a GP, that's a great place to start, because the benefits of weight loss surgery for all your patients who've got morbid obesity are pretty hard to argue with. I think surgery needs to be performed in the context of a multidisciplinary environment. I think surgeons who are performing weight loss surgery need to be able to be across a few procedures, because there's certainly not a one-size-fits-all for most patients. And we all need to be aware of the long-term implications of this sort of surgery, particularly with regard to micronutrient deficiencies. Thank you.